Hey guys, so today we'll be starting with your inflammatory bowel disease, alright, also known as IBD. So this is a small intestine pathology, alright. So let's start with its definition first. What does it mean? So IBD is a term which is commonly used to include or describe two idiopathic bowel diseases, alright. Now these two idiopathic bowel diseases have many similarities, but they have distinct morphologies, alright. So with that done, let's jump to the etiopathogenesis. Yeah, let's do the etiopathogenesis for your IBD. So the first topic we'll be reading under this is your inflammation related. Yes, so under this we have your interleukin 10 receptor polymorphism. Yes, and what is this responsible for? This increases the risk of childhood IBD. All right. The second is your interleukin 23 receptor polymorphism. All right, and what is this responsible for? Increase in your Th17 pathway. All right, and the third being your NOD2 polymorphism. All right, and this is the receptor for microbes. All right, so now the second etiopathogenesis we'll be dealing with is your autophagy gene related polymorphism. All right, so under this, the ATG16L1 polymorphism. All right, so this gives rise to two things. One is that it limits the autophages. All right, and second is your defect in Paneth cells. Yeah, and what does this lead to? This leads to decrease in your antimicrobial peptide. All right, and this leads to inflammatory bowel disease. All right, now before we jump into the pathogenesis, let's discuss the normal microbial flora of the gut. All right, so let's see what does this include. Firstly, it is your Clostridium species. Yeah, so these are the normal Clostridium species that are present in our gut. So what are they responsible for? They help in maintaining your T regulatory cells. All right, the second are your bifid bacterium. All right, this maintains your Th17 pathway. All right, and thirdly, we have your other bacteria which secrete something known as butyrate. All right, now this butyrate helps in your mucosal protection. All right, now with that done, let's jump into the pathogenesis. All right, so what happens in your pathogenesis is that there is some unknown insult to any of these three. Yeah, so what happens? There's an unknown insult. All right, now this leads to alteration in the normal microbial flora. All right, so what happened? These microbial flora that were there, they underwent some insult. All right, so what happens? These microbes, they release certain products. All right, and these products are then taken up by the cells. So what happens? These microbial products taken up by the cells in our body. All right, and what does this lead to? this leads to your NOD2 mutation. All right. Now, what was this NOD2 responsible for? We read here, yeah, for it is the receptor for your microbes. All right. So what happens here? This fires inflammatory cells. All right. So we have fired inflammation. And now this leads to three things. All right. The first, it stimulates your interleukin receptor. Which receptor? Interleukin 1. All right. The second was here, it increases interleukin 23. And lastly, it downregulates your interleukin 10. So these three factors together are responsible for the destruction of your intestinal epithelium. All right, which gives rise to the condition IBD, or inflammatory bowel disease. Now, like we read in the definition, IBD is a common term for two idiopathic bowel diseases. All right, now, what are those two diseases? First being your Crohn's disease, and the second is your ulcerative colitis. All right. Now, before we study these two individually, yeah, let's discuss them briefly. In a table format. All right. Let's understand, differentiate between these two. So first, your Crohn's, ulcerative colitis. So let's start with Crohn's. All right. This is a transmural inflammation. All right. Whereas your ulcerative colitis is a superficial mucosal inflammation. All right. In your Crohn's, we see granulomas. All right. Whereas in your ulcerative colitis, in severe conditions, it leads to the destruction of the neural plexus. All right. Now, the third, let's study the extent of your Crohn's. So now the Crohn's disease extends from your oral cavity to the anal cavity. All right, with rectal sparing. All right, that means the rectum is spared in your Crohn's. So as you can see here, the extent is from the oral cavity to the anal cavity. So this is a very long distance. So it's possible that the lesions can be here, or they can be present here, or then here, or then here. So these lesions are not throughout. So what do you call these? You call them skipped lesions. All right. So this is a characteristic feature of your Crohn's. The extent of the lesions are skipped. All right. Whereas for your ulcerative colitis, the extent, it involves the colon. So now you see the colon, a relatively smaller area compared to the Crohn's, where it extended from the oral to the anal cavity. So these show your characteristic continuous lesions. All right. Now let's come to the earliest findings. All right. Let's see the earliest finding in Crohn's. What do you see? We see something called as aphthous ulcers. All right. Now these are present usually in your unusual locations. They're more than 4 centimeter. All right, and these occur due to your stress. All right. Now these are self-resolving. If they do not self-resolve, these aphthous ulcers, they lead to your Crohn's disease. All right. Whereas the earliest finding for your ulcerative colitis is your mucosal irregularity. All right. So what else do you see in your Crohn's disease? We see increase in fissures. All right. We see fistula, and we also see sinus formations. All right. And why do we see these? We see these due to your tissue necrosis. And if you guys are done with your general path, you would know that tissue necrosis is the hallmark of inflammation. All right. Now, coming to the other part, we also see strictures here. All right. Now, these strictures are due to fibrosis. What fibrosis? Because of healing by fibrosis. All right. Now, coming to ulcerative colitis, we saw that the earliest findings were your mucosal irregularity. So let me draw this. All right. So this is your mucosa. All right. But you see ulcer. Now this is an ulcer. So what does it look like? You see that there's an ulcer here, and then the mucosa is going up. So it looks like a polyp, but it is not a polyp. All right. Looks like a polyp, but is not a polyp. That's why it is known as pseudo polyp, fake polyp basically. So what happens is the normal mucosa at edge of ulcer. All right. The pseudo polyp is nothing but a normal mucosa at the edge of the ulcer. All right. So that's something you see. Now coming to their gross findings. All right. All right. What do we see in a gross findings? We see something called as hose pipe appearance. All right. So I'll explain this by the help of a diagram. So normally, this is how the bowel is. All right. This is a normal bowel. Okay. Would you see these? These are called as your hostrations. All right. So what happens in Crohn's is that these hostrations undergo fibrosis. All right. So there's healing by fibrosis. We read that here. All right. So what happens is that you start getting these fibrosed. All right. So then what happens? All right. Now this, because of the fibrosis, we get the appearance of a hose pipe. All right. Now let's come to the gross findings of your ulcerative colitis. Here, what do we see? We see your lead pipe appearance. Okay. And why do we see these lead pipe appearance? Because these hostrations, all right, these hostrations here are lost. All right. So we get this kind of appearance, and this is known as your lead pipe appearance. All right. So here we can have two questions. All right. Where do you see your hose pipe appearance? That you see in your Crohn's disease. Where do we see lead pipe appearance? We see that in your ulcerative colitis. All right. So one more point under your Crohn's disease is that we see something called as serpiginous ulcer. All right. This is known as cobblestone appearance. All right. Because these ulcers give the look of a cobblestone, hence they're known as cobblestone appearance. All right. Now, let's see the involvement of your serosa. Okay. In ulcerative colitis, not seen, but whereas in your Crohn's disease, what happens is there is inflammation of your serosa, that is serositis. All right. Now, this leads to rupture. All right. The rupture hasn't taken place, it is about to rupture. All right. So, what happens? The mesentery comes over. All right. Like the mesentery comes over to protect the serosa. Like, all right, I will not let you rupture. So, this is known as mesentery protection. All right. Now, this leads to a very characteristic finding known as creeping pad of fat. All right. This is a very important point. Please do make a note of it. So, what happens if I have to explain it to you with the help of a diagram? So, this is your lumen. All right. I'm going to write L here. This is your lumen. All right, and here is your serosa. So here we have the inflammation, that is your serositis. All right, now, okay, so here we have your mesentery. Okay, and above the mesentery is your fat. All right, so what happens? The mesentery offers protection, and we see this fat here. All right, let me just finish the markings so that it makes it easier for you guys. So this was your mesentery, this was your fat, and here you see your creeping pad of fat. What does this do? It offers protection for the serosa, all right, due to the occurring serositis. All right, so this is a very characteristic finding. Please do make a note of it. Now, let's see what happens to the fats and vitamins. In your Crohn's disease, there is fat and vitamin malabsorption. Whereas in your ulcerative colitis, there is no fat or vitamin malabsorption. All right, now there is also your granuloma formation in your Crohn's. All right, now this granuloma is of non-necrotizing type. All right, and in your ulcerative colitis, what do we see? We see basal plasma cytosis. All right, all right, so let's study this with the help of a diagram. All right, so what do we see here? We see crypts here. All right, now this is your muscularis mucosa. All right, and we see plasma cells here, and this is your basal area. All right, so I think with the markings you're able to understand what is happening. Basal plasma cytosis. All right, so this was a finding in your, yes, ulcerative colitis. Now let's come to the investigations, the serology. All right, what do we see in your Crohn's disease? P ANCA 10 to 15% positive. Okay, and in your ulcerative colitis, your P ANCA is 75% positive. All right, now let's come to the management. It is surgery, but we did study that there were, the lesions, the extent of the lesion was too long. It extended from the oral cavity to your anal cavity with a rectal sparing. There were skip lesions, but the extent was long. All right, so there is chance that it can recur after surgery. All right, whereas for your ulcerative colitis, because there were continuous lesions and they were defined to a particular location that was in your colon, they do not recur after surgery. All right, now let's have a look at the complications. So the first complication we'll study that is common to both of these two, all right, that is your Crohn's disease and ulcerative colitis, is increase in risk of adenocarcinoma. All right, now let's go through the individual complications. For Crohn's disease, it is your spondylitis. All right, then there's your polyarthritis and pericolongitis. All right, whereas for your ulcerative colitis, we saw that there was neural plexus involvement. Yes, so due to destruction of the neural plexus, it gives rise to your toxic megacolon. All right, All right, now that we've differentiated between the two IBDs, that is your Crohn's and ulcerative. Let's study them individually, all right? And let's understand how do we format this answer into our question papers, all right? So what do we do first? We start with the definition or introduction. So how will we introduce Crohn's disease? We've already read it. It is an idiopathic, okay, IBD. All right, it's an idiopathic inflammatory bowel disease. And then we go to its extent. All right, we know it extends from your oral cavity to your anal cavity. All right, with rectal sparing. All right, so we've already done the etiology, we've done the pathogenesis. So let's jump into its morphological features. Yeah, what do we see? Let's start with the cross. All right, so you're going to say this along with me. You've read this. What was it? The first thing we saw skipped lesions. All right, the lesions were throughout, so they were skipped. All right, we saw skipped lesions. What was the second thing we saw? What appearance? It was your hose pipe appearance. Why did we see these hose pipe appearance? Due to healing by fibrosis. All right, so what happens? Let's see here. This was the wall of the bowel segment that was affected, healing by fibrosis. All right, and hence we got the name hosepipe appearance. Now let's come to the serosa. All right, what did we see here? It was studded with granulomas. All right, studded with granulomas. All right, now what did we see in your lumen? All right, now the affected lumen segment is narrowed. Okay, so it becomes narrow. Okay, the affected segment. Then what was the next point that we read? We read something about serpiginous ulcers, which are known as cobblestone appearance. Okay, so serpiginous ulcers, all right, which were known as cobblestone appearance. All right, now where is this seen in? The location of the serpiginous ulcer in your mucosa. All right, now what is the next thing we read? We read something about the fissures. Yes, so fissures. All right, then hallmark of inflammation. What was that? Tissue necrosis. And what did this lead to? This led to your increase in fissure and fistula formation, all right, along with sinus formation. All right, then what was the next thing we studied? We studied something called as creeping pad of fat. What was this creeping pad of fat? There was serositis. So then what happened? The mesentery offered protection, like, hey, take over my fat, and that formed a creeping pad of fat. All right, now, all right, so here's a rough diagram to understand these cross features that we studied. All right, so here we have your ileocecal junction. All right, and here we see your this particular area that we're going to be studying. This is the segment that is involved. All right, and we are studying Crohn's disease. So we know the first thing about Crohn's disease that there are skipped lesions. So this area is the skipped area. All right, so there are no lesions here. No lesions here. All right, now what do we see these? All right, these are your serpiginous ulcers. All right, now if you look at this like in a whole, this area, we get an appearance of a cobblestone. That is why this got the name cobblestone appearance. All right, I hope you got the concept here. Now we're done with the cross. Let's jump to the microscopy. All right, microscopy of your Crohn's disease. All right, so what do we see here? We see here we see your transmural cells here. All right, here, these transmural cells. So these give rise to your transmural inflammation. All right, we read about your granulomas, non-necrotizing type, non-seizating granulomas. Yes, here. All right, then there are areas of edema here. All right, and we see something. What is this? We see your deep fissures. All right, good. So these were the microscopic features for your Crohn's disease. We were already done with the complications. All right, so now let's study the clinical features for your Crohn's disease. All right, what are the clinical features? We have two clinical features here. One is your abdominal mass. All right, and second is your right side abdominal pain. All right, so now we're done with your Crohn's disease. Let's jump to ulcerative colitis. All right, so let's start with the definition for your ulcerative colitis. All right, how are we going to define it as? Yes, it is an idiopathic inflammatory bowel disease. All right, that chiefly involves the mucosa, and the submucosa of your rectum and colon. All right, now let's study how does this ulcerative colitis begin. All right, so it begins at rectum. All right, and then it extends upwards. All right, it goes up into the sigmoid colon, and from sigmoid colon it extends upward to the descending colon, and from there the transverse colon. So what do you see here? This has an upward pattern. All right, so what happens is that sometimes the colonic contents may backflow. Yeah, backflow as in, because these things have to go down. They might sometimes go up, they might go back. All right, and this is known as backwash ileitis. All right, now let's jump to the morphological features for your ulcerative colitis. Let's start with the gross findings. What do we see? We've already read it. We saw your continuous lesions. Yes, the continuous lesions involving your rectum and colon. All right. Second, what did we see? We saw a lead pipe appearance. Why did we see this lead pipe appearance? Due to loss of your hostrations. Yes, due to loss of hostrations. Yeah, I've already drawn the diagram. So this is how the bowel segment looks like. All right. There was another interesting thing that we read. What was that? That was your pseudo polyp. Okay, so basically we've read this. I'll be repeating it again. It's just a normal mucosa, okay, at the edge of the superficial ulcer. All right, this is the mucosa. It is not a polyp, it is a pseudo polyp, because, all right, so that's what was happening, and there is no involvement of serosa. We've seen the ulcers were superficial. All right, so here's a rough diagram. We can see your superficial ulcers here, and what are these? These are your pseudo polyps. All right, so now that we're done with cross, let's jump to the microscopy of your ulcerative colitis. All right, so let's start with the microscopy. What do we see here? We see your congested vessels. All right, we see that the vessels here are congested. All right, then we saw one of the most important things here. We saw your superficial ulcerations. All right, then we saw your mucodepletion, depletion of the mucus. All right, then we saw your inflammatory infiltration here. Yes, all right, and then we saw your cryptapsis. All right, but we did study a few other things. What were those? There was your basal plasma cytosis. All right, then we studied decrease in your goblet cells. All right, so there is decrease in your goblet cells, which is why we see your mucodepletion. all right, because goblet cells are responsible for secretion of your, yes, mucus, all right. And then we saw your, all right, so that was that. And now let's come to the clinical features. All right, so in clinical features, we have two clinical features for your ulcerative colitis. The first, we see rectal bleeding. All right, now this is one way to differentiate between your Crohn's and ulcerative colitis. All right, and the second thing that we see is your left side abdominal pain. All right, with that, we are done with your inflammatory bowel disease. I hope you guys found this video helpful, and thanks, and keep watching.